So Module 7 discussion, Stephen Hoff, Carrie Goat, Sigla Lirales, and Brianna Griffith. So case study. Mr. Jones is a 69-year-old man who was admitted to the hospital 10 days earlier with the diagnosis of acute diverticulitis. He was given intravenous fluids and empiric antibiotic coverage with ceftriaxone and metronidazole. His antibiotics were stopped after 7 days, and he continued to do well until today when he developed abdominal pain, fever, and diarrhea. A diagnosis of Clostridium difficile colitis was made and antibiotic treatment was initiated.
So what diagnostic test would confirm the diagnosis? There are a couple of tests you can conduct to diagnose C. diff. The tests can be concluded are stool toxin test. This test detects the presence of C. diff toxins A and B in the stool sample. This test is a quick test but has moderate sensitivity and can be used as a part of another test for confirmation. Polymerase chain reaction PCR test is the molecular test that can detect genes that produce C. diff toxins. It is highly sensitive and specific, and it is used as a rapid diagnosis and is specific. Glutamate dihydrogenase GDH antigen test screens for the presence of C. diff bacteria in stool samples. Since this test can't differentiate between toxigenic and non-toxigenic strands, this test is often used as an initial screen followed by toxin testing. Stool culture is the most sensitive method, stool culture for C. diff colitis. Although this test is rarely used because of the time constraints, anywhere from 48 to 96 hours to get the test results, and it would need further toxin testing to confirm toxicity.
Mr. Jones had several risk factors that contributed to his development of C. diff. The first one was antibiotic use. He was treated with ceftriaxone and metronidazole for 7 days, which can disrupt the normal gut flora. The loss of beneficial bacteria allows C. diff to grow and produce different toxins that cause colitis. The other risk factor that he had was the hospitalization. He's been in the hospital for about 10 days, and hospital environments can increase the risk of exposure to C. diff spores, which can be transmitted through contaminated surface or a healthcare worker's hands. And then the last factor that contributed to it was his age. At 69 years old, Mr. Jones his age puts him at a higher risk, as older adults have higher susceptibility to C. diff due to a weakened immune system.
And question C, vancomycin is a targeted treatment for C. diff colitis that minimizes systemic exposure while focusing on the colon infection. Vancomycin stays in the gastrointestinal tract after oral delivery, reaching high concentrations in the colon, which is home to C. diff. A targeted distribution strategy lets the antibacterial properties of the medicine do the work necessary for therapeutic success against specific infections. It is essential to emphasize that C. diff colitis is not treatable with intravenous vancomycin, which mostly stays in the bloodstream and does not reach sufficient concentrations in the colon. Vancomycin that is taken by mouth goes directly to the gastrointestinal tract to fight C. diff colitis, which makes it an excellent choice for the route of administration. In effect, it works like a local antibiotic to take down the bacteria, with the added advantage that it minimizes the chance of bad side effects throughout the body.
And then so the question that I made up was, what additional steps can be taken to prevent the reoccurrence of Clostridium difficile infection in Mr. Jones? So there are several ways of preventing Clostridium difficile infection from reoccurring in our patients. First, we want to be careful about how we're using antibiotics, because overtreatment or chronic use of antibiotics will only harm the patient's gut microbiota and can contribute to the reoccurrence of infections. If future antibiotics are needed moving forward in the patient's treatment, it would be worth using narrow spectrum antibiotics as they are less prone to destabilizing gut bacteria. Furthermore, infection control protocols, including proper hand hygiene and cleaning surfaces with bleach-based disinfectants, can help deter the spread of spores in healthcare settings. Recent treatments like fecal microbiota transplantations may be attempted in severe or recurrent cases to help restore normal gut bacteria balance and prevent a reoccurrence of the infection. Monitoring and ongoing care are also important in catching early signs of reoccurrence.